We are Group 2, and we are proposing to create a biocompatible septal occluder for tissue growth.
Atrial septal defect is a form of congenital heart disease where communications between atria fail to close at birth. This is illustrated in the figure on the right. You can see there's a hole in the interatrial septum that allows for a mixing of oxygenated and deoxygenated blood. There are 5 different types of atrial septal defects that are classified by the defect location along the interatrial septum. It is estimated that about 25% of the general population has a patent foraminovalle, which is the most common type of atrial septal defect. To put that into perspective, that is about 82.5 million people in the United States alone. Large defects that fail to close can provoke complications such as stroke, pulmonary hypertension, and dysrhythmia. To illustrate how atrial septal defects can provoke a stroke, a blood clot can form anywhere in the body. Once the clot dislodges, it enters the systemic circulation and eventually the heart. With atrial septal defect, the clot can pass through the defect and exit the heart via the aorta. Once this happens, the clot can travel anywhere in the body, including the brain, where it causes ischemia and tissue death. This happened to me last year, as you can see by the infarct on my MRI. I had to have my defect closed to prevent any recurrences. There are 2 types of treatment for atrial septal defect. Surgical treatment is used when there is conflicting anatomy or device explantation where a different method of closure needs to be utilized. The more common treatment is percutaneous intervention that involves the use of a cardiac catheter to place a closure device. Surgical treatment of atrial septal defects typically uses a median sternotomy, which can be seen in the figure on the left. In this procedure, the sternum is sawed in half and separated with a retractor to gain access to the heart. Cardiac catheterization, which is significantly less invasive, is illustrated on the right. In this procedure, an incision is made, most commonly in the groin, and a catheter is advanced through the femoral vein or artery to access the right atrium. For small, uncomplicated defects, the defect can be closed by direct suture. Larger defects usually require a patch repair. The patch can be made of either human or bovine pericardium, the sac that surrounds the heart, or synthetic materials such as Dacron or Teflon. Advantages of using surgical intervention is that it's an effective closure method that provides a sufficient seal. Disadvantages of surgical intervention are that the procedure is highly invasive, which increases the risk of bacterial infection and the cost of the procedure.
Percutaneous interventions involves placing a septal occluder to plug the defect. This procedure is visualized in the picture on the right. The device folds out to the tip of the catheter and is pressed against the side of the defect. The catheter is retracted and the device is deployed on the opposite side of the defect. In the US, there are 2 companies with the FDA-approved devices, which are included in the table. The devices are made out of nitinol mesh with either EPTFE or polyester membrane. The advantage of these septal occluders is that they provide a minimally invasive closure option that can create a 100% seal. The disadvantage of these devices are that they can elicit unwanted tissue responses, and the nitinol can degrade, which can require revision and exploitation. To address the shortcomings associated with the other marketed devices, our team is proposing a device with a design that minimizes the risk of pulmonary hypertension, dysrhythmia, and strokes, and it will also help in reducing foreign body responses, preventing toxicity and allergic reactions associated with nickel that is present in the nitinol wiring used in the current devices. Furthermore, our device promotes tissue proliferation and growth, thus stopping any tissue erosion and preventing scar tissue. Finally, since our device does not have these complications associated with it, we do not suspect the need for revision surgery, thus eliminating any additional costs associated with any surgery. Our occluder design will be a flat dumbbell-shaped porous scaffold with seated cell patches on the insides of each end, as well as cells seated over the connector. The occluder will be inserted through a current method with the use of a catheter and will be placed with an end on either side of the ASD with the connector through the center. When placed correctly, the cell patches will touch the septal wall, and the dimensions of the device are listed on the figure shown. The ends are twice the size of an average ASD since this is not a self-centering design, and the connector length is the average thickness of the septal wall to ensure the device doesn't migrate.
scaffold will be composed of collagen type 1 and silk fibroin in a volumetric ratio of 7:3. Based on the dimensions of the device and material properties, the amount of material used to fabricate the scaffold will be approximately 6 milligrams of collagen and 598 milligrams of silk fibroin. The collagen and silk fibroin will be electrospun to create the scaffold of our device. Electrospinning is a process where high electric fields are applied to rotating cylinders, which align the fibers and create the scaffold. The anticipated tissue response of the scaffold is that it will be integrated and not encapsulated, as the porosity will help the cells grow into the three-dimensional scaffold. The materials of the scaffold will not evoke a foreign body response, as collagen is an abundant protein in the body, and the silk used in the scaffold will be boiled in sodium carbonate to remove sericin prior to use.
The scaffold will be sterilized using ethylene oxide infiltration. Ethylene oxide is an alkylating agent that inactivates microorganisms by denaturing their proteins, enzymes, and nucleic acid. Ethylene oxide is an effective sterilization technique because it can penetrate deep within surfaces and utilizes lower temperature than other sterilization processes, which can help prevent degradation or denaturing of the scaffold. This method of sterilization meets international standards, which require the probability of contamination to be less than 1 in a million. Terminal sterilization ensures this higher degree of sterility and is repeatable. To ensure our sterilization is in accordance with ISO 11135, we plan to use a procedure proposed by Monaco et al. After exposing the scaffolds to ethylene oxide, they will be aerated with warm air at atmospheric pressure for 2 days to eliminate any toxic ethylene oxide. Studies have shown following this procedure minimizes the residual amount of ethylene oxide to less than 1 microgram per centimeter squared.
The cell patch component of our device will consist of cardiomyocytes, hepatocyte growth factors, or HGF, and insulin-like growth factor 1, or IGF-1. The cardiomyocytes will be derived from induced pluripotent stem cells, or iPSCs. The amount of iPSCs needed is roughly equal to the amount of cardiomyocytes needed. The cardiomyocytes are seated at 100 million cells per patch, which is approximately 250 million cells total. The cells will be cultured, and then gene transfection will be performed to incorporate the DNA of HGF into half the cardiomyocytes and the DNA of IGF-1 into the other half, and then they are seeded onto the scaffold. Gene transfection is a process of opening pores into cell membranes in order to introduce genetic material into cells, which in this case means introducing the DNA of HGF and IGF-1 into cardiomyocytes. The anticipated tissue response of the cell patch is that the cell proliferation and tissue synthesis will occur. HGF will migrate cardiac stem cells to the site, and IGF-1 will allow them to proliferate. Both of these growth factors will help create an ideal environment for cardiomyocyte development. In combination, this will induce tissue synthesis. Our projected cost for the materials we have proposed is approximately $3,500, which is sufficiently less expensive than the existing devices on the market, which have a base cost of around $8,000. This is disregarding the fact that the prices could rise to over $50,000 if there are unforeseen complications with the implementation of the current devices. As shown in the graph, $3,500 represents the cost of purchasing the material in bulk and storing them in cryofreezers to preserve them to be used to make up to 8 devices, placing the cost of one device at $300. We expect our clients to be heart surgeons in hospitals, and we anticipate the cost would be at least partially covered by the patient's insurance.
To ensure functionality of the device, we will be performing mechanical testing. This testing will be performed on the collagen silk scaffold, and any methods used are based upon previous completed studies. Static tensile testing will be conducted with an Instron 5848 microtester system. The sample will be pulled until failure, and the resulting force and modulus will be compared to the known value for cardiac muscle tissue, which are approximately 4 newtons and 111 kilopascals respectively. Dynamic mechanical analysis will be performed to observe the stiffness of the sample. This will be done by testing the sample for its responses to sinusoidal stress at different frequencies and observing the deformations. The value for stiffness will be compared to the known value for cardiac muscle tissue, which is 10 to 15 kilopascals. The last test that will be performed is deflection testing. This test will utilize contact mode atomic force microscopy to measure cantilever deflection. The probe will be in contact with a thin cell layer of the collagen silk scaffold. A force indentation curve will be produced, and the elastic modulus of the sample can be determined and compared to the known modulus of 111 kilopascals. We'll also be testing the biocompatibility of the device. The first round of testing will be performed in vitro and will test the cytotoxicity and hemolysis. To test the cytotoxicity, a procedure according to ASTM F813-20 will be followed. Positive, negative controls, and testing cultures of subcutaneous connective tissue will be used. Samples of the device will be placed in the test cultures. All 3 culture types will then be analyzed after 1 day for any signs of abnormal morphology and lysis, and the results will then be compared to the control groups and an accepted grading scale. Some limitations are that this test does not use cardiac cells and it is not performed in vivo. To test for hemolysis, a procedure according to ASTM F756-17 will be used. For this test, positive and negative controls, as well as testing blood samples, will be used. Before and after the addition of the control factors and the device sample into these groups, a cyan methemoglobin test will be performed to determine the hemoglobin concentration of the blood. The results will then be compared between groups and between results from before and after sample and control factors were added. The limitations are that this test is performed in a controlled environment. Along with in vitro studies, in vivo studies will also be performed. The models used in these studies will be rats, as they are the standard small animal model. The first test is an intramuscular implant test in accordance with ASTM F763-04. There will be a test group that receives a device implant in its gluteal muscle and a control group that receives a collagen implant. The implant sites will be evaluated for any histopathological differences between the control and the device implant to monitor inflammatory responses, thick scarring, and other unwanted effects. Limitations are that the device is not being tested with heart muscle and that the immune response may be different between rat and human models. The second test that will be executed is a carcinogenicity test in accordance with ASTM F1439-03. For this test, samples of the device materials will be implanted onto the heart of the test group. The models will be analyzed for any signs of tumor growth, and hematology and blood chemistry assays will be performed after termination. These results will then be compared to those of a control group. Limitations, again, are that the samples implanted on the outside of the heart, which is not the exact end-use location of our device, and that rats may produce different immune responses. The final test that will be performed is an in vivo animal trial. This study will be performed according to procedures set forth in ASTM F981-04, as well as previous studies. For these tests, we will be using porcine models and will be aiming to test the efficacy of the device. The device will be implanted as it would be in a human model and will remain implanted for 2 years. Throughout the study, tests such as bubble contrast echocardiography, angiography, and fluoroscopy will be performed to ensure that there is no blood crossover. Additionally, the site will be monitored for any cellular immune responses and thromboemboli formation. Limitations are that the porcine model reactions may not directly correlate to those of human model reactions. Additionally, group sizing may not be large depending on what will be statistically significant.
With our device, there are benefits and some drawbacks. The benefits of the device are that it's minimally invasive, prevents the need for future revision procedures, and it's relatively cheap compared to other devices on the market. It's also biocompatible, and it will promote tissue proliferation and synthesis to repair the defect. Yet the limitations are that the device would require longer manufacturing processes due to the need to culture and proliferate the myocardiocytes. Furthermore, the silk degradation may pose an issue depending on the tissue proliferation rate. And lastly, there is still the potential for a foreign body response since it's not a naturally occurring scaffold in the body. Thank you. Questions?